Nadia device 1 second. How challenging is the revision if you revise it and redirect it?
Well, first of all, we did try bone graft substitute for a while and it was unsuccessful. So allograft bone is our recommendation. Removing the implant, a Diana is relatively simple. It's easy to find. It's always in the same location. Sometimes, even though it's just held in by fibrous tissue, it takes some strength to back it out, but it's not more difficult than that. Just the implant is cleaned out of soft tissues and inserted, reinserted, and then backed out. Moving it distally has always been possible. The implant tends to fail if it fails, let's say it's proximal, and it is successful and more under compression if it's distal. So it meets the radiologic landmarks. Actually, it's never happened that we could not put in an implant, a revision implant, in a circumstance where there was malposition. So we're confident about that.
Thank you.
The question I have, John, is I always think of the dorsal part of the sacroiliac joint like a tension band, the way the ligaments are so robust in that direction. And that's typically where the bone is the least dense, especially the cortical bone, which when you look at the anterior portion of the joint in the synovial region, it's much more dense subchondral bone. So I was just wondering what the difference is and how you describe it as more of the compression area for a keystone versus, what I just said.
Yeah, well, the deep fascia there is longitudinal to our incision. It's so that if there's a tension bend there, we're making our incision parallel with the tension. So it's not pulling apart. That's one thing. Secondly, when we were, at the beginning, the Diana method was specified that we would go through the recess and that we would use the helical sizers to size the recess. Now that the implant has been moved distally, we, first of all, need only 2 sizes. And remember that the implant goes all the way to the S1, S2 junction at the SI joint, and the bone is very dense there. And the third thing is the trajector, that tube, the asymmetric tube, prevents violation of the sacral cortex. We preserve the sacral cortex as somewhere where the implant would rest. At the beginning, before there were instruments, the implant would subside on the sacral side, but it has not subsided on the sacral side since we developed that so-called trajector, the asymmetric tube.
I have a question.
Yes.
How complicated is the technique? I know my friend in Stockholm, Andreas Westberg, he tried to do Diana, and he had to revise about 50% of his cases. And I don't, is it easier with Nadia technique? And how complicated is it to come to another surgeon? Because if it's too complicated, then it's quite risky. In your hands, no problem, but in the other hands, what do you think?
Yeah, it's very definitely, the Diana especially was very technique dependent. And the recess is an operation in itself that had to be cleaned out, prepared, and bone grafted. And some surgeons have more success with that than others. Since the Nadia is now hydroxyapatite and titanium plasma spray coated, we haven't had any revisions. So, and it's also moved distally, it's more under compression, and it's a much narrower area of the extraarticular recess. So it seems like the Diana could be made to work. For example, Volker made it work very well, and other surgeons did as well, but not everybody could. And so the technical improvements were to make it more useful in the hands of more surgeons.
May I add to that?
Hey, Werner.
It's nearly without complications. We never had in 80 cases any vascular or neurologic complications. And even I am possible, for me, it's possible to make this without complications. And seems difference between Nadia and Diana. I had some loosenings of Diana, and then up to now saw never a loosening of Nadia.
Very good.
Okay, I think we can